Hi, thank you so much for that introduction and good morning to everyone. My name is Lauren Fishbein from the University of Colorado, and I'm here today to talk to you about inherited risk factors for neuroendocrine tumors. When I was given the title Inherited Risk Factors for Neuroendocrine Tumors, I thought, what really does that mean? And the way I interpret it is that these are inherited genetic predisposing conditions to developing neuroendocrine tumors. And so, if we want to talk about inherited genetics, we have to understand the difference between inherited and tumor genetics. And so, when I'm talking about inherited genetics, I'm talking about inherited mutations or germline mutations, as we call them. These are changes in the DNA that we are born with, and it occurs in every cell in our body, and we can test for them by testing using blood or saliva. And these mutations in the DNA can predispose us to developing tumors. On the other hand, if we talk about tumor genetics, we're talking about tumor mutations or somatic mutations. This is when that DNA change occurs in just one cell in the body initially, and then that cell proliferates and grows and forms into a tumor. And in this case, we can find the change in the DNA only in the tumor cells and not in the rest of the cells in the body. And this can be useful sometimes because it can help us direct therapy in certain cases. But today we're really going to stick to talking about the inherited genetics throughout the whole body. So, inherited genetics predisposing to neuroendocrine tumors. When we think about this, we can think about each type of neuroendocrine tumor and think about the genetics and inherited conditions associated. So, for example, pancreatic neuroendocrine tumors. About 10 or 15% of them are associated with genetic syndromes, which you can see listed here on the slide. This means, though, that most pancreatic neuroendocrine tumors are sporadic, meaning they happen by chance and not due to inherited risk factors. The next type of neuroendocrine tumors I'm lumping together lung and small intestine neuroendocrine tumors because these are both rarely associated with genetic syndromes, but they can be, and if they are, they're usually associated with multiple endocrine neoplasia type 1. The next neuroendocrine tumor you may be less familiar with, this is called medullary thyroid cancer. And I bring it up because it's the only type of thyroid cancer that's a neuroendocrine tumor, and 25% of people with medullary thyroid cancer have a hereditary cause, and that cause is multiple endocrine neoplasia type 2. And we'll talk about all of these conditions in a little bit. The next type of neuroendocrine tumor I want to discuss is the PHEOCHROMOCYTOMA and PARAGANGLIOMA. These are neuroendocrine tumors that form in the autonomic nervous system, inside the adrenal gland, or throughout our whole body on nerve ganglia. And up to 40% of these are associated with hereditary syndromes, and there's several syndromes associated, as you can see listed here. So let's take a moment and review all of these syndromes individually. We're going to start with multiple endocrine neoplasia type 1. This is caused by mutations that a person is born with in the MEN1 gene. The gene makes a protein product called menin. And what you can see in the graphic is that menin is involved in turning on and turning off many different genes within the cell. So if there's a mutation or a DNA damage in the menin protein or MEN1 gene, we're going to have dysregulation of the expression of lots of other genes in the cell, and this can lead to tumor formation. The most common type of tumors associated with multiple endocrine neoplasia type 1 are the 3 Ps. Pituitary adenomas, and the pituitary gland sits at the base of our brain and regulates lots of other endocrine organs and hormones in our body. The second tumor type associated are parathyroid adenomas or hyperplasia. The parathyroid glands sit behind the thyroid in our neck, and they regulate calcium levels in our body. The third P are pancreatic neuroendocrine tumors, and up to 30 to 70% of people with MEN1 will develop pancreatic neuroendocrine tumors. While these 3 Ps are the most common tumor types associated with MEN1, there are several other neuroendocrine tumors also associated. And those include GI neuroendocrine tumors, thymic and lung neuroendocrine tumors, and very rarely adrenal tumors that are neuroendocrine PHEOs can be seen. The next syndrome to discuss is von Hippel-Lindau disease. Von Hippel-Lindau disease is caused by mutations that someone's born with in the VHL gene, and the VHL gene creates the VHL protein. This protein is in charge in our cell of creating new blood vessel formation. So if there's a mutation in the VHL protein, more new blood vessels are going to be made, and they supply tumors to get enough nutrients and oxygen to grow. So mutations in the VHL protein or gene are going to enhance tumor formation and development. And patients with von Hippel-Lindau disease develop kidney cancer, hemangioblastoma, which are tumors in the central nervous system, pancreatic neuroendocrine tumors, as well as pheochromocytomas. Neurofibromatosis type 1 is the next syndrome associated with these NETs, and NF1 is caused by mutations someone's born with in the NF1 gene, and that gene makes a protein called neurofibromin. What you can see in the graphic is complicated, but it's showing you that the NF1 gene is involved in regulating cell proliferation. So if there's a mutation in the NF1 gene, the cells proliferate unregulated and develop into tumors. And patients who have NF1 develop several criteria, which you can see listed here. Here are some pictures to show you some examples of cafe au lait spots, which are basically birthmarks, freckling in the underarm area, iris hamartomas, which are almost like freckles on the iris, as well as neurofibromas, which are nerve sheath tumors. Patients with NF1 can also be at higher risk of developing pheochromocytomas and pancreatic neuroendocrine tumors. Although both of these neuroendocrine tumor types are not part of the diagnostic criteria for NF1, people with NF1 do develop those tumors at a higher rate than the general population. The next syndrome is called multiple endocrine neoplasia type 2. While MEN2 shares a name with MEN1, it's a completely different syndrome, and it's caused by a mutation someone's born with in a completely different gene. In the case of MEN2, the gene is the RET gene and the RET protein. This protein sits on the outside of our cells and triggers our cells to inhibit the breakdown, or what we call apoptosis, and stimulate proliferation. So if RET is mutated, it actually turns on the RET gene in this case and triggers more growth and proliferation of our cells, leading to tumors. And patients with MEN2 develop two different types of neuroendocrine tumors: medullary thyroid cancer in almost all patients with MEN2, and pheochromocytomas in about half the patients. The next syndrome is hereditary paraganglioma and pheochromocytoma syndrome. SDH, or succinate dehydrogenase complex, is the cause of this syndrome. So this complex is made up of 4 genes and a cofactor, so 5 total genes in this complex, and a mutation in any one of them can predispose to developing pheochromocytoma and paraganglioma. This complex exists inside the mitochondria in our cells, and the mitochondria in cells are the powerhouse organelle. They create the energy and metabolism for our cells. So a mutation in these subunits will create a mess up in the metabolism of our cells and can lead to tumor formation. The other tumors associated with SDH mutations besides pheochromocytoma and paraganglioma include kidney cancer and GI stromal tumors. So inherited genetics, who should be tested? If someone has one of these neuroendocrine tumors, should they be tested for any or all of these type of inherited syndromes? And the answer is not necessarily. Luckily, we have guidelines. The American College of Medical Genetics have established guidelines for many different cancer types, including neuroendocrine type tumors. These are examples I extracted from these set of guidelines, and I'm going to use the pancreatic neuroendocrine tumor as an example. So I mentioned earlier that someone who has pancreatic neuroendocrine tumor, about 10 or 15% of the time, it may be associated with one of these genetic conditions. But that means that 85 to 90% of the time, it just occurred by chance. So there's no utility in testing every single person with a pancreatic neuroendocrine tumor for one of these inherited syndromes. However, the guidelines have a few recommendations. For example, if a person has a pancreatic neuroendocrine tumor And another feature associated with MEN1, for example, like parathyroid adenomas or a lung neuroendocrine tumor, then those patients should be tested for MEN1. If a patient has multiple tiny neuroendocrine tumors in the pancreas, that is often associated with MEN1 diagnosis as well, and those patients should probably be tested for MEN1. And a gastrinoma is a special type of pancreatic or duodenal neuroendocrine tumor. And patients who have this is very rare to have that outside MEN1, so those patients should also be tested for MEN1, for example. And there are guidelines for the other neuroendocrine tumors as well for when people should be examined for an inherited risk factor. So why do we care if someone has an inherited mutation that predisposes them to these tumors? Well, the reason is it will help us guide them in screening and surveillance for other associated conditions with that syndrome. And it also helps to determine their family member's risk. So if the family member gets tested and doesn't have the gene, they're not going to be at higher risk for developing these type of tumors or syndromes. But if the family member has not developed a tumor yet and does have a gene identified, it helps us screen them appropriately to hopefully identify tumors sooner. Now, I get asked a lot, will every person with an inherited gene mutation develop a neuroendocrine tumor or another feature of these syndromes? And the answer is no, they won't. The penetrance, we call it, the risk is not 100%. But it helps us screen so that tumors can be found early and hopefully cured with surgical intervention. So hopefully today I've given you a little bit of an update about precision medicine and using a person's DNA to help guide screening, surveillance, and treatment. And in the future, I'm very hopeful that research will get us to a point where we may be able to use our DNA to guide us for prevention, to predict who will get disease and who won't, and maybe answer how we can prevent disease as well. So thank you for your time and attention, and I appreciate you watching today.